Hej, välkomna till det här webbinariet som har namnet Tystande som medicinsk praktik. Vi kommer att hålla den här sessionen på engelska, men vi har en simultantolk till svenska. Och om du vill höra den så trycker du på den lilla jordgloben som ligger nere i Zoom-fönstret och aktiverar simultanöversättning till svenska. Okay, so from now on then, I will go on in English. Welcome to this webinar, which is named The Medical Practice of Silencing, after the book Unheard, The Medical Practice of Silencing, by today's speaker, Dr Rageshri Dhairyawan. My name is Katie Collmar. I'm a resident doctor of oncology, and I sometimes assist Posithiva Gruppen in their educational efforts, especially regarding healthcare personnel and the care of the trans and gender non-conforming patients. And I'm very honored to be the moderator of this webinar. Dr. Dhairyawan's presentation is estimated to run about 40 minutes. And during this time, we encourage you to submit any questions you might have via the Q&A function. And then we will address them at the end. During the Q&A session at the end, we also encourage you to use the raise hand function and ask questions verbally. This webinar is organized by Posithiva Gruppen and their knowledge network for women living with HIV. In its work, this group has spoken to women living with HIV about their experiences of being dismissed, silenced, or ridiculed in healthcare settings. These women have described a sense that they are expected not to complain or not to be difficult, but rather be grateful to be alive. Some have spoken to their healthcare providers about their concerns regarding adverse effects of their HIV therapy, or they have had questions regarding menopause or breastfeeding or sexuality. But I found that these concerns were dismissed as less important in a context where adherence to HIV treatment was always the priority. Knowledge Network for Women Living with HIV has worked for some time to raise awareness of these power dynamics in healthcare settings and of the use of master suppression techniques and how this affects women living with HIV. And today's webinar is a part of their work, and we hope that it can be a small stepping stone towards a different kind of HIV care, perhaps one that looks further beyond the viral load and looks more at the patient behind the blood work and the context around this patient. So we are thrilled and very grateful to welcome today's speaker, a consultant physician in sexual health and HIV, a prolific researcher with a number of publications in the field of HIV care, often with a focus on intersectionality and sociopolitical aspects of healthcare. She is also the author of Unheard, The Medical Practice of Silencing, which is a book I strongly recommend if you haven't read it. So please let's give a metaphorical digital round of applause for Dr. Rageshri Dhairyawan.
Thank you so much for the lovely introduction, and thank you for the invite. It's such a pleasure to be here, and it's wonderful to be speaking in Sweden. I wish this wasn't a virtual webinar. I wish it was in person, but thank you so much. So I'm going to share my screen now, and then I'll start the presentation, and there'll be time for questions at the end. Okay, so as mentioned, I recently published a book called Unheard, The Medical Practice of Silencing, which has taken a lot of my experiences as being both a patient and a doctor and a researcher to really think about how silencing of voices can really impact on patient safety and health inequalities. So how did this all start? This all started for me a few years back, around 12 years ago now, when I was a patient. So it was a moment that really changed me and inspired the book. So 12 years ago, I was trying to get pregnant and wasn't able to get pregnant. And during the investigations, I was diagnosed with endometriosis, which is a very common menstrual condition. And it meant that I was needing to have fertility treatment. So I was having IVF treatment. And during my third cycle of IVF, I developed excruciating abdominal pain after the eggs had been collected. And this was very different to what I'd experienced in my previous cycles. And I was very worried that I had a known complication of IVF called ovarian torsion, which is a surgical emergency. So my husband was out that evening. He came home to find me on the floor of the bathroom in extreme pain, and he took me to the emergency department at the hospital, and I was treated very well there. They gave me morphine and they admitted me for more investigations. And luckily for me, when they did the scan, they found that I didn't have ovarian torsion and I didn't need surgery, which is a good thing. And the medical team felt that it was the hormones from the IVF that was making my endometriosis worse, and giving me the worst pain that I'd ever had. So although I didn't need surgery, I still needed to be in hospital for pain relief. But it was when I was on the ward and asking for pain relief, I realised that the nurses and the medical team didn't believe me when I said I was in pain. They dismissed my concerns. They treated me as if I was making it up just to get morphine. And it was a very shocking experience for me because, you know, I'd never been dismissed in healthcare before. And it was really hard for me to complain because I didn't want to seem like a nuisance on the ward. And I have worked on wards where there are the difficult patient, who's the patient which people think are, you know, attention seeking, and they often get worse care. So I didn't want to be that patient, so I didn't complain. And it was only through my husband, who advocated for me, that I got the pain relief that I needed, and I was sent home after 3 days. And when I went home, I thought, should I complain? But I decided not to make a complaint because I just wanted to forget about it. I was glad to be out of hospital. And reflecting on not complaining at the time, not complaining afterwards, a few months later, I realised that I had started to feel really guilty that I hadn't complained, because I thought, if this could happen to me, I am someone who's well educated, I'm a doctor in the healthcare service, a senior doctor, I can speak English, I didn't have something life-threatening. If that could happen to me, what on earth happens to everyone else who doesn't have my privileges? And I started to feel really guilty about that. And I felt like I had been silenced, both when I was on the ward and when I got home, by the medical team who were responsible for my care. And what this really taught me was that in healthcare, we always tell people to speak up for better healthcare. We say patients should shout for better care. But actually, when you're at your most vulnerable, it's really difficult to speak up. We can't expect patients to speak up for better healthcare. We, working in the healthcare system, need to listen to our patients so that they don't have to speak up. So this was really what made me write my book. And Unheard is really my exploration of who is listened to and taken seriously in healthcare and who isn't. How this leads to the culture of medical silencing, which is bad for patient safety and makes health inequalities worse. And it's also really about knowledge. So who is deemed to be a credible producer of knowledge? Whose knowledge do we value and listen to? And it's meant to be a positive book, so it's really thinking about how we can tackle these systems at different levels and really address them. So this is a quote from Arundhati Roy, the Indian writer, which I really love. So she said, "There's really no such thing as the voiceless. There are only the deliberately silenced or the preferably unheard." And this really made me think about my patients. So I work in a part of London which is quite poor. There's a lot of migrants. There's a lot of people who are coming from marginalised groups. And I thought, you know, my patients are not really seen when it comes to government policy or in policy documents. And they're not silent. They are trying to speak up, but they are the ones who are silenced or not unheard. So I wanted to write the book for them as well. And the third reason I wanted to write the book was really because I've been a doctor for 20 years, And despite my best intentions, I cannot say that I have listened equally to every patient I've seen in the 20 years. And I really want to understand what it was that made it hard for doctors like me makes it hard for us to listen well. So the book is also a mirror onto me as a healthcare professional and my role in medical silencing as well. So I'm just going to take some water because I've got a bit of a cough. So, how patients are silenced. This is a quote from a medical historian, Eleanor Cleghorn, which talks about her experiences of being silenced. So she said, "My lupus diagnosis was devastating, but it was also a relief. I'd experienced the pain and humiliation of having my symptoms dismissed since my early 20s. Countless times I tried to explain my persistent pain and swollen joints to doctors, only to have my symptoms written off as hormonal, psychological, and even a possible pregnancy. I'd been on the receiving end of withering glances, eye rolls, smirks, and heavy sighs. I was young and full of feelings. I started to believe I must have been making it up, that the pain was all in my mind. Guilt and shame gnawed at me until I didn't trust my body anymore." And I think this is something that lots of patients, particularly women, do describe experiencing in healthcare, which really shouldn't be the case. So I tried to really understand why this happened. And one of the frameworks that I discovered came from philosophy. And this is a framework that I use throughout the book in different ways. And it's called epistemic injustice. So epistemic is another word for knowledge. So this is an injustice around knowledge. And it comes from philosophy, this concept. So it's defined as a wrong occurring to someone in their capacity as a knower. And it was coined by the British philosopher Miranda Fricker in 2007. So part of what makes us human is our ability to produce knowledge and to pass it on to someone else and to feel like we've been listened to and heard. And when that doesn't happen, we experience this epistemic injustice. So it's part of what makes us human. And in healthcare, if you experience epistemic injustice, it is like being dehumanized. And epistemic injustice sits alongside a broad pattern of social injustice. So it happens to people who are more likely to experience other types of social injustice. And Fricker came up with two types, testimonial injustice and hermeneutical injustice. But since 2007, other philosophers have really come up with a broader version of this, some of which I will go through here. So what is hermeneutical injustice? So this occurs when the experiences of marginalized individuals or groups are not understood by themselves or by others because those experiences do not fit any concepts known to them or others. And this is really due to the historic exclusion of groups from activities that produce these concepts. So an example is in healthcare is when patients are unable to communicate their knowledge to healthcare workers in a way that could be understood. So, for example, when patients are describing symptoms of pain, they will describe their symptoms in their own way, but it may not be in the way that we in healthcare have been taught to understand pain. So when the patient is trying to explain something to us, we don't understand them. And that really means that we don't necessarily get what they're trying to say. So the patient may experience an injustice because we don't share those same concepts because we've been taught differently. And I think the most common type of epistemic injustice we see in healthcare is testimonial injustice. So she defined this as occurring when a person's voice or knowledge is discounted or dismissed due to prejudice from the listener about their social identity. So it's when someone speaks up and they're not believed or they're dismissed, and they encounter what Fricker called a credibility deficit. So when they speak, they're not seen as being credible, and they're taken less seriously. And it's often due to prejudice around the speaker's gender, their ethnicity, their class, their sexual orientation, their ability, their age, or religion. So for me, I think I experienced testimonial injustice because I was seen as being a young woman of colour on the ward and therefore someone not to be taken seriously. And in the UK, for example, there are stereotypes about South Asian women being very anxious, attention seeking, even described as being princesses. So, you know, having symptoms that we think are physical, but are actually all in our head. So I think those stereotypes really played into the treatment that I got. So I think anyone can experience testimonial injustice one or two times, but the problem is when an individual experiences it multiple times, it becomes cumulative. And also when it is not just occurring to them from individual doctors or healthcare professionals, when it's coming systematically. So the system as a whole doesn't believe you. So that's when it's at its most harmful. And just to say, testimonial injustice means that people are seen to be less credible when they speak, but actually some people are also taken too seriously and they can have credibility. And this is often, for example, well-educated, well-spoken white men who are often taken very seriously and thought to be good authorities when they speak, even if they're not speaking something they know about. So how does this play out in healthcare? So on individuals, when people aren't believed, they go to their doctor, they're not believed, they feel dismissed, they feel disbelieved, they feel gaslit, and they feel unheard. And this causes real harm. So we know that if you're not taken seriously by your doctor, you're less likely to get investigations. It means your diagnosis is delayed and your treatment is delayed. And this also has an impact on the doctor-patient relationship because it really builds mistrust, because why would you trust your doctor if they don't take you seriously? And it can lead patients to avoid going back to healthcare. And this constant disbelief may lead patients to stop talking. So they may self-censor because they think, what is the point in speaking my truth to my doctor if they don't believe me? So they just may stop telling the doctor what's really going on. And this has been termed testimonial smothering by another philosopher called Christy Dotson. So this is really about you smother your own testimony because there's no point speaking up because you're just disbelieved again and again. And I talked a little bit about credibility excess, which is when you're taken too seriously. And this can also cause harm in healthcare. So patients who are taken too seriously by their doctors will say they have a symptom and the doctor will say, yes, then you will definitely investigate you and treat you. So it may lead to unnecessary over-investigations and treatment, which can also cause harm. And why is this a problem? Well, this is a huge patient safety issue. And when we look at patient safety reports, we often see one of the root causes is that patients said they had something wrong and they weren't believed. So one example is when it comes to maternal mortality. So that's women who die during pregnancy and just afterwards. In the UK, Black women are 5 times more likely to die, and South Asian women are two times more likely to die than white women in pregnancy. So once again, when you look at the reports, it said that the women said they thought something was going wrong in their bodies during the pregnancy. They were told, no, what you're experiencing is normal, and this led to catastrophic effects. So, you know, the women may have died or their babies may have died. And this is more likely to happen to women of colour who are less likely to be believed than white women because they have a credibility deficit. And another example is sickle cell disease. And this is a government report in the UK, aptly called No One Is Listening, which talks about deaths of people with sickle cell disease in hospital, people who are often Black, who are not taken seriously when they go into hospital saying, I think I'm having a sickle cell crisis, I need pain relief, I need oxygen, I need to see a specialist. Again, they're treated as being drug abusers who are falsely trying to get pain relief. And this has led to some very tragic deaths of young Black men in hospital in the UK. So another example of testimonial injustice, a big patient safety issue. And I wanted, because you guys are an HIV organisation and because I'm an HIV doctor, I wanted to give an example which comes from my clinic, and I do use it in the book, an example of testimonial injustice. So I'm the doctor in the HIV clinic, and my patient is saying to me they are taking their HIV treatment every day. And their HIV treatment every day, you would expect that their HIV viral load is 0 or undetectable. But their blood tests show this is not the case. Their blood test is telling you that, their viral load is 200,000, 240,000. So you think, why are they telling me they're taking their medications, but they are not undetectable? So you do some further tests. You look to see if there's any resistance to the medication. There's no resistance. You do therapeutic drug monitoring, which is to see whether there is any drug in the system, in the blood. But that test suggests there is no drugs in the system. The patient is not taking any medications that interact with the HIV medications, which mean that they won't work. And the patient is not experiencing diarrhea or vomiting, so there's no reason why the drugs aren't being absorbed. So you think, what is going on? There's a clear discrepancy here. The patient is telling you they're taking their medication. The blood tests are telling you that they are not, because that is the conclusion from these test results, is the patient is off their medication. So this is a scenario that is not unusual in the HIV department, and I have had several patients where this has happened, and it's a very difficult scenario when you're a doctor, because you just wonder, why isn't your patient just being honest with you and telling you the truth? Why aren't they listening to me? But there are obviously lots of reasons why the patient may not want to tell the truth to their doctor. And the scenario I use in the book is, this is a patient who has come off their medication, but doesn't want to tell the doctor because they want to be seen as the good patient. And they have had problems with their medications for the last year. So they've had severe side effects, and they are very worried that the medication is too strong for them. And every time they've told someone in the healthcare team, they've been told, it's normal, it will get better, you just have to put up with it. So they've really tried to get help, but they haven't been taken seriously. No one has said, okay, why don't we change the medication to something else, or you come off it for a while and see if you feel better. And instead, they have stopped it themselves and have felt better. So this, I think, is an example of testimonial injustice, because the patient has tried and tried again to get healthcare professionals to listen to them, to believe them and take them seriously. And because they haven't been, they have self-censored and stopped telling their truth to the doctor. So this is testimonial smothering. And I think this is something that can happen in many disease areas when we try to understand why patients don't take their medication like we want them to. So I've talked about how epistemic injustice can have harmful effects on individuals, but it has even more far-reaching impacts on groups of patients who go unheard. So I'm going to use women as an example here. So I have endometriosis, which, as I said, is very common. It affects 1 in 10 people who menstruate around the world. And in the UK, the average time to diagnosis is 8 years. And this is a time that is actually getting longer. And when you think about endometriosis, despite it being so common, there's a lot that we don't know about it. So we don't know the cause. We don't know how it affects fertility. We don't know how to diagnose it except by having surgery. And we don't know how to treat it. We don't have a variety of ways in which to treat it. So why is this very, very common condition? Why do we have such little knowledge about it? And we know that women have suffered painful periods for a very long time. It's been documented in medical literature 4,000 years ago. But we do know that historically physicians have been male, and women's pain over millennia and their concerns have been dismissed as hysteria. So women have been told, your symptoms are actually due to your emotions. It's all in your head, and pain is part of being a woman. So this not listening to women as a group historically for years and years has meant that endometriosis has had less focus and been less of a priority when it comes to policy and research. So we have less knowledge about it now. And this really means that we have these knowledge gaps. And this still continues. So in the UK, we know that 1/3 of women experience some kind of gynecological issue in their lifetime. But despite that, less than 2.5% of publicly funded research is allocated to women's health. So these knowledge gaps are continuing to happen, but I do think it is getting a bit better. And we know that these knowledge gaps happen because groups of patients go unheard. So women have been historically unheard, as I said, for centuries, but it's also when minoritized doctors and researchers go unheard. So I don't think it's a coincidence that we've had more research in women's health as we've seen more women reach senior leadership positions in medicine, in the medical profession, and in research, which means they're more likely to be interested in women's health as an issue in endometriosis and more likely to try and get funding to research it. So who is in leadership when it comes to medicine and research is very important also when it comes to knowledge gaps and trying to fill them. And this silencing of patient groups and of researchers can also happen on a much larger scale in global health. And we know, for example, that communities in the global south who live in often the poorest countries are much less likely to be heard when it comes to research and policy, so much less likely to get funding. So global health is a field that has its roots in colonial medicine, and some of these power imbalances still take place. Because when we think about epistemic injustice and who is seen to be credible, when it comes to producing knowledge, it is often institutions and researchers in the global north, so Europe and North America particularly, who are seen to be better at doing research, more credible when it comes to coming to do research, and more likely to get good results. So they are the people who get all the funding to do the research, even if their research is in the global south on people in the global south. So again, when we think about who has credibility in HIV research, it's often researchers in the global north who get the funding rather than the researchers and communities in the global south for whom HIV mostly affects. So I've talked about how epistemic injustice can really affect people who are minoritized, so people who suffer bias. But actually, there is a form of testimonial injustice called pathocentric testimonial injustice, which says that people experience testimonial injustice because they are patients. So being a patient can put you at risk of a credibility deficit. And this was coined by two philosophers here in the UK, Habby Carrell and Ian James Kidd, who have done most of the literature and philosophical work around epistemic injustice in healthcare. So people who are chronically ill may suffer the stereotypes of being chronically ill. So your doctor may think you're unable to communicate or unable to understand, or you're confused because you are ill, or because you are ill, you are too close to your illness and you cannot be seen to be objective. So these stereotypes may mean that you are taken less seriously by your doctor. And actually, when I was doing my research, I found there is this innate doubting of patients, actually, which has been, again, around for centuries. And there was documented an Italian physician in the 13th century wrote down, there was a physician in Italy in the 13th century who thought that his patients were lying to him. They were giving him urine samples, but he thought they were giving him other people's urine samples. And he so believed his patients were lying to him that he wrote advice for other physicians on how to find out if your patient is lying to you. So he actually wrote 19 pieces of advice to how to work out if your patient is lying. So I think this real, doubting of patients, skepticism of patient testimonies is actually ingrained in the medical profession and is really part of our training. We start off from doubting patients and we expect patients then to have to persuade us for us to believe them. And this can sometimes even be seen in the language of medicine, which can come across as being skeptical. So we talked about certainly in the way I was taught in the UK, we talk about the patient denied something or the patient claimed something, which starts from this inherent skepticism. And I think patients who are most likely to be disbelieved are patients who, as well as patients who are minoritized because of their gender, their class, their ethnicity, it's also because of what conditions you have. So if you have a condition that is difficult to diagnose and to treat, you are much less likely to be taken seriously, because I think that as doctors, we are more comfortable with being able to deal with patients who have diseases that we know how to diagnose and treat, because, they have objective signs or symptoms. But for conditions which are more contested or which there are no easy diagnostic markers, we are more likely to disbelieve the patient. So I'll give you an example of long COVID. To diagnose long COVID, there aren't specific tests that we can do. We have to rely on patient testimony, and that makes it harder as us, the doctors, to know if the patient is telling us the truth or not. So we are more likely to disbelieve patients with conditions like that. So I think, sadly, these are patients who say they are more likely to be silenced by their doctors because they are conditions that we're not comfortable discussing because we don't know how to treat patients with these conditions. And really, when we think about patient voice has actually been downgraded as a source of evidence, as a credible source of evidence for a very long time. And again, this has happened for centuries. And just to give you an example, when we think about evidence-based medicine, so this is what we base our clinical guidelines on, it should be on good research, so we're offering the best treatment. When we think about what is the research that we think is most credible, most valuable, the hierarchy of evidence, it's all numbers. The ones at the top is all based on statistics because it's deemed to be more objective. And of course, statistics are really, really important and the base of evidence-based medicine. But if you look at our hierarchy of evidence, how we grade evidence, there is nowhere in this kind of hierarchy anything that foregrounds patient voice. So, there is no qualitative research, for example, which is often very useful to really help us understand statistics and how things work. So I think this is an example of how patient voice has been downgraded in research and in what we consider to be good medical evidence over the years. But I think obviously very important to say that patients have for centuries not been kept silent, and they've really fought to be heard. And I think it's really important here to, in the book, I write a chapter on this, and I do use HIV/AIDS as my example of patients who have really fought to be heard. And this is the logo, Silence Equals Death, of ACT UP, which I'm sure you've heard about, but is the activist group, which is now a global group. Who came about in the 80s, a group of people who basically fought and advocated for attention and research onto HIV. And it still exists today. And through the many different types of activism they did, be that on the streets protesting or in boardrooms or with drug companies, they basically changed how HIV is as a condition in 30 years. So, going from no treatment, certain death, to effective treatment within 30 years. So if they had been kept silent, if they hadn't spoken up, everyone would have died from HIV. And of course, so many people did. So I think, it's a great example of patient activism fighting to be heard as a group, which has really changed the course of a condition. And they also changed what it meant to be a patient. So because of the work they did in scientific communities, working with drug companies, with the government, they proved that patients and their lived experience are a valid source of medical evidence. So they changed how science is done. They changed our notions of who is seen to be a credible producer of knowledge. We now respect lived experience more than we did. We should respect it more. And it changed how clinical trials are done and also how healthcare is done. So, I think HIV activism is an amazing example of how patients have really changed medicine for the better. And in the book, I do argue amplification of patient voice in all aspects of medicine and healthcare research. I talk about valuing lived experience to an equal degree to medical expertise. But we need to do this in a really ethical way. We need to listen to patients and other marginalized people in an ethical way. So this is a great quote from a book called The Patient Revolution. And this woman says, "In healthcare, we have the idea that anyone can do it. Oh, just go out and get some patients and talk to them. But no one ever thinks about why patients should come and talk to you. Why should I give up my time to come into some crappy building at 2 p.m. on a Wednesday where you get a bad cup of coffee? It's not a nice experience. Give people nice food, give them a thank you, give them a present, something to say thank you for donating your time. I find there's a lot of take, and not a lot of giving back." So I think this is, again, not an uncommon experience. And I think the problem is if we don't treat people well when they speak up, we're at risk of exploiting them. And it's not easy for people to speak up about traumatic lived experience again and again. We really need to think about how to support them better. So I have a chapter on this in the book. So, as I said, I really argue for the amplification of patient voices, increasing patient involvement in medical education as part of health service development, in research, so thinking about co-producing research, community-driven data, also increasing the diversity of trial participants, and also including patient voices so that health promotion is culturally appropriate. But we also need to amplify voices in an ethical way. So we need to provide patients who are doing this work with adequate support. So that may be pastoral support, so giving them emotional support if we're asking them to speak about their difficult experiences. So that might be checking in with them afterwards. We need to train patients for these roles so they feel that they have the skills to do it. And we need to make sure that they are paid, and that paid must be monetary. So, you know, we are paying them for their lived experience and their expertise and other experience they may come in with. So we need to make sure that they are paid equally. We need to include diverse patient voices. So obviously not everyone has the same opinion, so we need a variety of voices. And if they recommend a change, then we should act on it. We need to listen and show that we take them seriously and make sure changes occur. This slide is thinking about other reasons why doctors don't listen, which I'm only going to talk about very briefly, and we can maybe talk more in the Q&A. But of course, there are lots of systematic reasons why in our workplace and in our education we don't listen well. So it's the way that we're educated, it's the fact that we work in very busy, stressful environments, and all those things can make it harder for us to listen. So if we're busy, we're stressed, we don't have time, there's no private spaces to have conversations. It's also hard for us when we don't see the same patient each time. You know, all these things are coming out of medicine at the moment and they need to be kept in. We need to really think about that doctor-patient relationship and how we can encourage it. We also know that doctors who are unwell, so doctors who are burnt out, are not able to listen well. So I think it's important that doctor well-being is seen as being a part of patient safety. And we're also not really incentivized to listen well. So when we think about productivity in healthcare, we often think about numbers of patients seen, number of diagnoses made, number of treatments given. But listening is not seen as being a productive tool, when really it is. We know that if we listen well to patients, if they feel heard, that in itself can be therapeutic. And that's not really recognised or valued in our training, and we don't have the time to do it. And I think often when a patient tells us difficult things, they tell us about a problem that they find, you know, we can't help them, we can't fix them. As natural fixers in medicine, we become uncomfortable and we may shut the patient down because we don't want to hear more about their back pain that we can do nothing about. So the patients feel shut down and silenced. But if we recognise that if we just listen to them, bear witness to their suffering, we are doing something therapeutic. So I think that's something that needs to be recognised more. So I'm going to finish here with a few questions to you and to think about what makes it hard for you to listen, because even with best intentions, we can't listen well all the time. So when is listening hard for you? How do you know when you need a break? What are your blind spots and potential biases, and when do they come out? So maybe, again, when you're tired and stressed, that you may reach to stereotypes when you wouldn't normally. What can you do to be more prepared for uncomfortable conversations? So if you think, I know there's going to be a difficult consultation coming up, how can you prepare yourself? That might be making sure that, you know, you've had a break, you've eaten something, or you've spoken to a colleague and they've given you some advice. So you are prepared to be your best self in that consultation. And for me, I know listening is hard when I am halfway through my clinic and I'm a bit hungry. So I will take 2 minutes out to eat a banana and then do the second half of my clinic, because I know I'm much better after that. Also thinking about how can you be more curious and open when you're listening? So how can we listen with less judgment? So we may not agree with our patient, and this is not about agreeing with everybody, but listening to our patient, recognizing that what they're saying is a valid point, even if we don't agree with it, is really important. So we can be more curious, we can be more open when we listen, and we can listen with less judgment. And by doing that, by not telling the patient they're wrong, then we can open up dialogue, we can hear their questions, and hopefully we can really answer them and, you know, have further conversations. And finally, how can you make your patients feel heard and reassured that what they say is important to you? So these are kind of questions to the clinicians who are here today to think about. But actually, it's not just patient-doctor consultations. It can be in your workplace, in your private life, for anybody really. How can we be more prepared for those conversations where we find it hard to listen? So in clinic, I've just talked about things that you can implement. So we know that listening is hard, it can be uncomfortable. So if we can implement places for us to have supervision or reflective practices or debriefs, so trying to get more of those into our workplace means that we can talk about when listening has been hard and learn from others. We need to obviously get feedback from our service users, but it's important about whose voices are we not hearing and why, and how can we reach out so we hear more voices. And when we're doing service development, really think about it with an equity lens. So if we're making changes, how will they affect the most marginalized people who we serve? And obviously continuing learning to learn about equity issues that are specific to our patients. So in conclusion, medical silencing is historical and remains pervasive. Listening is a tool for improving patient safety and health equity. And by listening to the voices of the most marginalised, we will improve healthcare for everyone. So by doing it, it's better for all of us. And as I said, listening does not always mean agreeing, but may open up a dialogue and build trust. And we really need systematic and institutional solutions to do this. And I go through that at the end of each chapter in my book. And I wrote an essay on this topic for The Lancet a few months ago, which they very kindly put a quote from the essay on the cover. So I'll just read that out because it kind of says everything I want to say. So at the core of patients not being heard is the unequal power dynamic between doctor and patient. Each holds a different form of expertise. It is vital that we combine this expertise and collaborate. So I always give further reading. These are books. So there is Unwell Woman by Eleanor Cleghorn, which is the history of sexism in Western medicine. It's a really fascinating read. Lots about hysteria in there. A colleague of mine, Annabelle Shoamimo, who works in sexual health, has written Divided, which is an excellent book on the history of racism in medicine. And this book by Catherine Mannix, who is a palliative care doctor, has really written a book, Listen, about how to have uncomfortable conversations at work and in your own private lives, which I found very useful for advice. So I end by saying thank you very much for listening. That's my book, which is available through all the usual places you get books. That's my email address. And yes, thank you so much. I'll stop screen sharing now.
Thank you very much. That was a very lovely presentation. We have actually gotten a lot of questions, both live during the presentation and a couple from the work group we've had before. So I hope we'll have time for as many as possible, at least. One that just dropped in here that I think is very interesting as a clinician who's sometimes struggled a bit reading your book with my own emotions. What response have you gotten regarding the book from doctor colleagues? Do people recognize themselves? Do they find it helpful? Or are they angered, confused? How do they feel?
A very good question. And I was really scared when the book came out because I thought this might be an issue. I thought I'd be the most hated doctor in England. But actually, it's been the opposite. I've had really, really positive responses. I've been asked to speak to many different doctor groups. And I think it's because we recognise as a profession that this is happening. Some of it is our fault. Some of it is institutional and systematic. And often we may silence patients without even realizing that we do it. So I think there is a feeling that we want to do better. And it's really nice to see other clinicians thinking the same. And also we're all going to be patients at some point, and many of us already are, as well as being doctors, and if not, we all will be. So we need to improve healthcare. And this is a way also of improving health inequalities.
Absolutely. That is actually a beautiful segue into the second question here, which is Sweden is said to be a very equal society. And I think many doctors think that they don't have prejudice towards women, for example. And I would also add, I think many Swedes and many Swedish doctors don't believe that colonialism really has anything to do with us, which of course we are part of and have always been. Doctors think they're always objective and always mean well. In your experience as a patient and as a doctor, is there something a patient can do to get doctors to take them more seriously?
Yeah, I think it's very hard when you don't recognise there's a problem. And part of the work that I have been doing is trying to produce research which shows there are these inequalities. So my research in HIV has been about racial inequalities and gender inequalities. And, you know, even if people say this is not a problem in this country, you show them the statistics, the research, and you say, this is a problem, or this is the qualitative research with accounts from patients which tell you what they're experiencing. So they cannot deny those objective truths of the patients and the statistics. I do have a list of things that patients can do to advocate for themselves in the book, because although my argument is you shouldn't have to, you need to, because the healthcare system is not perfect. So I think as a group, patients are brilliant for activism and advocating, and I think that's something that you should do together. And I know you guys are already doing it, I'm sure, as part of this group. As individuals, when you go to see your doctor, I would recommend, one, to prepare very well for the appointment. So make sure you write down any questions that you have so you don't forget when you go in there. And if you have any, test results or letters from other doctors, discharge summaries from hospitals, just take it all in with you. We especially want a list of your medication. So this makes you prepared. You're giving the doctor the information they want, but you also know what you want to ask for. And if you need an interpreter or you have other, accessibility needs, then the clinic is aware and can prepare for you. Also, I would say, don't be scared to bring someone with you. At the moment, my parents aren't well and they're having hospital appointments, and either me or my sister is going with them, because if you have someone with you, they're there to stick up for you. They can say things that you may not feel able to say, and they may remind you about the things that you haven't asked about. And, you may be getting results that are very emotional. So you've got someone there who has a record of it. And lastly, know your rights. So you have a right to good healthcare. So you can ask for a second opinion or a third opinion. You can make a complaint. There are lots of things that you can do. So, and I think people get scared to ask for a second opinion. But actually, as doctors, we often ask our colleagues if we don't know what to do. So we are always asking for second opinions ourselves from colleagues. So don't be afraid to do it. But I think if you have someone with you, it can make you feel braver. But you shouldn't have to, sadly.
Yeah, no, absolutely. Okay, I think we have, you did cover some of this in your presentation, but we have a question. You write in your book about the culture of knowing better that develops in med school. Would you care to elaborate on that, and if there's anything in med school education that could be adjusted to change this?
Yes, so there's a very sad, famous case in the UK recently of this thing about doctors knowing better. There was a young girl called Martha Mills who died in hospital of sepsis after she had an injury to her pancreas from falling off her bike. And her parents are journalists and have fought to change the system since this happened. And what happened is they kept saying, our daughter is really ill. We would want her to be seen, should she go to intensive care? But this was a very famous hospital. It had lots of very expert physicians, and everyone in the staff, I think, were too scared to question the professor who was in charge of her care. So there's this real medical hierarchy of power. So people were too scared to question the person in charge. And this is a huge problem in medicine. And in medical school, you are made to feel that you are the best. You're the most important students. You will save lives. So you're treated like you're special. And I think this continues. And I think the hierarchy of medicine is, doctors at the top, and then you get other healthcare professionals like nurses, dietitians, psychologists, and then at the bottom, sadly, is patients. And that power imbalance has to change. And I think in medical school, we could have some training sessions with other healthcare professionals. So if we sometimes did some training with nurses, then we would understand that their knowledge is, have amazing knowledge. It's just different to us, and both types of knowledge are important. And if we can include patient involvement in the curriculum and also get patients coming in to talk to students right from day one, I think that power imbalance may shift a little bit.
Absolutely. Okay. I have received a question which is a little personal in nature, so I hope the person asking doesn't mind me paraphrasing a bit and making it a bit more general. But it regards a person living as a refugee who has recently restarted their HIV medication, and they have endured severe side effects, but also, and maybe more importantly, if I understand them correctly, a lot of stigma and a lot of isolation. And they ask, how can they stay strong to stay on this medication? And my thinking is, in the context of this webinar, maybe how can we support this person, we as healthcare personnel or as people who run them, how can we support them, patients who struggle to stay on medication due to side effects or due to stigma?
I think we have to recognize, first of all, that it is really hard to take medications every day. And I think there is this thought from us that, you have life-saving medication, why can't you just take it? It will save your life, but we have to understand, people can have terrible side effects. There's lots of other things going on in people's lives, which mean HIV is not the most important thing for them, and taking their medication and going to clinic is not the most important thing when they're just trying to keep their families safe and fed. And of course, the stigma of people may not know that you have HIV, so having to hide medications, all of that makes it very difficult. So I think as healthcare professionals, I think we can talk to our patients about it. We can start the conversation instead of waiting for them to talk to us about how difficult it is. So, we should be asking, how's it going with your medications? Are you getting side effects? How is it in your, we should be finding out about people's home situations. Where are you storing your meds? Do people know? How can we help you with this? So I think it is about being proactive and also using every member of our clinical team. So not just the doctor, the pharmacist to help. If you're lucky to have a community nurse who can come out of clinic to speak to patients, all those things can help. And in the UK, we have lots of links to HIV charities where they offer advice on immigration, on benefits, on housing. And that's an important part of our work, is to help people with their social situation, so that, the things that make it hard to stay in HIV care and take treatment, we can hopefully try and help a little bit if we can.
Yeah, thank you. One of the women in the project group wrote a question. I believe that the use of master suppression techniques comes from a place of fear. Do you think this is right? And if so, what do you think healthcare personnel are afraid of? Why do they?
I think there is an element of that. I think we're afraid of being wrong or of not knowing something. And I think a lot of medicine is uncertain. I think there is a statistic that 30% of patients who go to their family doctor have symptoms that are unexplained. And often the symptoms will go away by themselves and you never find out what happened, or they're a condition perhaps we have still to find out more about. So I think in medicine, we like to think that we know we have the answers. And, you know, and because we want to help people, we want to fix people, it's really difficult when we can't. So I think that's what we're scared of, not being able to help people, not being able to understand. And that's what I was saying, that, you know, just a simple act of listening sometimes is helpful and therapeutic, but we don't recognize it as such.
Yeah. That also comes back to the to being a bit humble as
yes.
So we don't know. There's a lot we don't know.
Exactly.
A question from one of our female members that I found a bit remarkable as a clinician was they had experienced being silenced by healthcare personnel who would just talk about themselves. One member described being scared in need of support right after they got their HIV diagnosis, and their social worker was talking about their own health and their own experiences. It seems like this is familiar to you.
I think I've seen it sometimes. It's not something I have written in the book, but I can imagine that happening. And again, you wonder, why are you? I think it's sometimes if you're comfortable to share a little bit, but essentially you are there to help the patient in front of you. It's about them. It's not about you. I don't understand why people do that.
But it does a bit go into the who is the focus of the consultation. You know, is it about me solving an issue or solving a problem, or sharing something with the patient, or about me listening to the patient, sharing something to me? Okay. There's a question: how should we as professionals approach doctors with this kind of perspective? I don't understand the perspective. The person who asked this, would you like to ask this verbally and elaborate?
Hi, it's Joachim from Gothenburg.
Hi.
You hear me? Hi.
Yes.
Yes. It was about this perspective of raising this awareness, because we have problems to reach out to the doctors, the nurses and the counselors. We reach out and talk about these kind of questions, but not so much the doctors. So it was interesting to hear when the book came out and what's the reaction be, but how can we reach out and let the doctors understand that they need this knowledge? And
I think you need to get some doctors on your side. I think that often helps. So, you know, you may have some doctors around here who are on your side and understand. And unfortunately, I think doctors listen most to other doctors. And I think that's why my book has done well, because I am a doctor, so I can talk from my perspective. And that, again, shouldn't be the case. They should be listening to patients and other healthcare professionals. But if you have a doctor who's on your side, they can start spreading the message, be that through teaching or recommending my book or you know, or whatever. But
of course.
I do know of patients who have given the book to their doctors, which is interesting.
Thank you.
Good idea to me.
Yeah.
Okay. Thank you very much. Okay, I think we are running out of time, so we will have to let this mark the end of the webinar. I would like, on behalf of Posithiva Gruppen, to express our immense gratitude to you, Dr. Dhairyawan, for donating your time and talking to us. So thank you very much for that.
Thank you for listening, everyone. It's been great.
Come again?
I was saying thank you for listening, everyone. It's been a really great conversation.
Thank you. As we just said, I would really like to recommend the Unheard, the medical practice of silencing, especially for everyone working in healthcare. It's a must read.
Thank you.
Okay, thank you so much.